Well, we went deep into treatment last time, and we've been dancing around it this conversation as well. I think before we proceed, it's important we cover off what that is. And you've talked about the glutamine and the glucose. So let's just, and again, this comes back to the fact that all cancers are treated the same under this theory. So it doesn't matter what kind of cancer example we use here. Let's just call it cancer. So somebody has cancer and they want to take on this quote unquote alternative treatment. How do they begin?
I saw, you're 100% right. I saw a lot of the comments say, oh, he talks about this, but where do you go? Yes. Where do you go? And you know where they go? They go to Dana-Farber, MD Anderson, and Sloan Kettering, and Moffitt Cancer Center, Fred Hutch Cancer Center, and all these different, the James, you name it. They go there and they say, I want metabolic. Oh, there's no evidence to support metabolic therapy. So where are these poor folks going to go? I mean, they should be banging the doors down in their hospital and say, I want metabolic therapy. And then they get belittled and ridiculed, and they get a cold shoulder. I mean, this is nuts. Why are they doing it? And they're all, I agree with many of the comments. They're saying, oh, Seyfried talks about this, but where do we go? All right, why don't you try going down to your local cancer center and see what they say? And they're going to tell you, what I'm saying I never heard of this. He doesn't know. He's not this. He's not that. And so those kinds of comments are superficial. You tell me what part of the scientific research that I have done that you find is not supported. Okay, you show me the evidence that what I'm saying is wrong. You show me a cancer cell that can live comfortably without glucose and glutamine. Then maybe I'll say, I really want to know about that because I've been looking for that for 40 years and I haven't found it. I want to know about that. So, so you can't, there's no clinical, you can't do what Seyfried says because there's no clinical trials. Well, what the hell? Well, why don't you do a clinical trial? And they're, we can't do it. You can't do the clinical trial. Why not? Well, blah, blah. It costs money to do these clinical trials. Who's going to pay for this clinical trial? And then they say, if we do a clinical trial, we have to do for standard of care first. We need to poison and irradiate you, and then maybe we'll consider metabolic therapy. No. You consider metabolic therapy first. If it doesn't work, you can always go back and do the crazy stuff that you do. So, and I feel for the people. I feel bad about this whole thing myself. I feel bad because I understand the biology of cancer. We have a pretty clear idea of how it works. We have case reports showing that these things work, okay? And that why is nobody doing it? Where are the clinics that should be doing this? Why doesn't Dana-Farber step up? Why doesn't MD Anderson step up? Why don't these big hospitals that should step up? Okay, because they're all chasing genes. They're all looking at gene mutations that are largely irrelevant to the cancer, right? So they go, you got the BRCA1 mutation, you got the FDF insulin epidermal growth factor mutation, you got P53 mutation, who cares? The bottom line is that they're using glucose and glutamine to stay alive. Why don't you go after the glucose and glutamine? Most of the mutations are largely irrelevant. So you're taking biopsies of people, getting useless information, and then we'll go about treating them with stuff that largely doesn't work for many, many people and charging them a fortune for it, okay, which is outrageous. You're charging, this is another outrage, this financial toxicity stuff. We published a paper on, it is criminal, it is immoral to do that to people. If you're treating them with something and they get sick and they die, and then you charge them all this extra money for this is immoral. This is a moral issue here. Don't get me started. I have to deal with this stuff all the time. It's unbelievable. And all I do is I make sure that the research that we publish is accurate. And then they say, we've worked very, very hard on doing and setting up these kinds of experiments so that we can get accurate results. And then when we put them into the clinic, like those few MDs and clinics that are willing to try to do this, they get really good results. Is everybody cured, or is everybody no? Is everybody cured and managed using toxic radiation and chemo? Give me a break. But we generally see a better quality of life. Overall survival is improved and quality of life is improved. Is there resolution? I don't know. How do we know resolution? I told you, Jesse, right? If you die like at 95 years old and you had colon cancer when you were 30, and you died from a heart attack and the colon cancer never came back, I would say that guy was probably cured. But in the meantime, how many good years can we get out of somebody who was, in fact, diagnosed with an aggressive kind of metastatic cancer? And I think that's the success rate. If you can double overall survival relative to what's being done today, then I consider that success. Would you consider that success?
Yes.
All right. Well, there it is. Right. So, so you have to then try to figure out, well, you should get guests on here, on your podcast, and ask them those kinds of questions. Why are you guys not using metabolic therapy? Right? And see what kind of answers you get. It's very interesting. Instead of having me on here, why don't you go out and get some of the guys running the big cancer clinic? Go get the head of cancer biology down here at Dana-Farber, MD. Get those guys in here. And oh, well, we did research and we didn't support what Seyfried said. Oh, yeah? Well, where is it? Publish it. Show me. For clearly what you're doing is not working. So, you have to kind of rake it up here a little bit and see what's going on.
Well, I can see and hear your passion, and I feel the same, and I feel for people. And here's the thing.
I know. I feel for them too.
You can understand how you mentioned the comments, how somebody coming across this information, hearing us talk, they feel that little bit of hope and see that there is something out there that could be a benefit. And then there's this extra layer of the fact that they can't even try it.
Yeah.
So it's like it's almost like not worse, but there's this extra layer of insult because they know there is something and they don't even have access to it.
Well, that's the patient. Yes, they know there's something else that could help them. And they go to their professionals and the professionals say, no, that does not exist. Or if it were important, I would have known about it. Or you get a whole slug of different kinds of responses. And then you heard some of the comments. The patients went in and asked their physicians. They said, oh, no, sugar. You can't take sugar away. Sugar is essential. I mean, this is nuts. I mean, these people are living in the Stone Age, for crying out loud. I mean, they have very little understanding of the very biology of the disease they're working with, whether it's the physician or the nurse. And I think that's not entirely their fault. And you saw so many, very few few physicians at all get training on the power of diet and lifestyle issues to manage chronic disease. They're getting training that does not involve the very essence of what they need to know about how to manage cancer. And don't forget, we have people who are told, you got to stop. You got to stop eating carbohydrates in your diet. You need to lose a lot of weight naturally to reduce your risk for diabetes, cancer, and this. And there's a lot of people who don't want to hear that either. They say, "Can you give me a pill?" Well, the pharmaceutical will be very happy to give you pills, but the problem is, as you said at the beginning, it's us. Okay, it's largely us. We can shoulder a lot of the burden. If we put ourselves in the position to get cancer in the first place, we can also take ourselves out of that position and try to help ourselves. So metabolic therapy is different than all other therapies because it requires a significant participation on the part of the patient. If the patient participates in the healing process, they will benefit. Okay, so it's significant. What does that mean? Well, you're going to have to radically change your diet and lifestyle in order for your body to get healthy again. Okay, and if you're not willing to participate and do that, then you are prone to have this condition persist and possibly kill you. So I think there has to be an education on the part of the patient as well as on the part of the physician.
Coming back to that point you made earlier about me bringing on these conventional docs and trying to discuss some of these issues we're talking about today, that at this point at least isn't something I'm interested in. Arguing and bumping heads and causing all this negativity. The path I've chosen is to bring on people like you and bring light to these other messages. And the fact is that this can come from the patient up. I know, unfortunately, for the people that are stage 4 right now and they don't have a lot of time, this isn't going to be easy for those people, or maybe they don't have time on their side to act in this way. But unfortunately, with the platform I have, I think the best thing I can do is use it to bring light to this information and for people to learn about it. And then hopefully, you mentioned earlier, banging on the doctor's door and saying, this is what I want, because you've been trying to do it the other way, bring light to this new information, and in a large sense, it's ignored. And for somebody like me, I also don't have the science background like you. So I go talking with one of these doctors. It's not like I'd have to bring you on and you'd have to get into the science and be able to have a knowledgeable scientific conversation. I'm the middleman who is here to extract from your brilliance.
I completely understand your situation. I completely understand your response to what I said. And cancer is an extremely contentious field. It's been that way from the very beginning. Because the implications are so profound to who we are as a species, who we are as a person. It cuts across all of these different kinds of things. But then again, when folks hear what I say, they get like fired up and excited and give them hope. And then when they go to their clinic or their oncologist, they get dashed down. And then there's this level of frustration. And so what do you do? I feel so bad. And because they say, oh, where are these clinics? You know where they are? They're in your local hospitals. Okay, that's where they should be. Why are they not the ones adapting this metabolic therapy? You have these giant monster cancer centers. The MD Anderson Cancer Center. We have Dana-Farber, Sloan Kettering. These are multi-million-dollar institutions with all of this stuff going on. And when people get cancer, they go there. And they say, we have that's all based on the concept that cancer is a genetic disease. So right off the bat, you're getting a treatment not based on the concept that cancer is a mitochondrial metabolic disease. Now, I know a lot of folks don't know that. And they get frustrated. And I don't blame them. How do you think I feel? When I talk to those guys, and most of the time they don't want to talk. They don't want to get involved. They don't. And if they do, there's another layer of research here that you don't know about that I have to deal with. And that is those scientists who say Otto Warburg was incorrect in his assessment of cancer as a metabolic disease, because cancer cells are taking in oxygen just as readily as normal cells. Therefore, they're not what Warburg said, dependent on fermentation, because their oxygen consumption is very similar to that of a normal cell. And what we have found in our research is the oxygen consumption in the cancer cell is not being used efficiently for the production of energy, whereas in the normal cell, it is being used. So they're assuming that oxygen consumption by itself means that the cell is getting energy from oxygen. In normal cells, that is true. In the cancer cells, that is not true. Okay? And there's a huge research emphasis showing how cancer cells have normal oxidative phosphorylation. No, they don't. They have oxygen consumption that's not linked to efficient energy production. Now, this is a layer of depth that only a very few people could really dig deep into, because it's the foundational basis for what Otto Warburg in the 1920s and 30s said, that the ability of a cancer cell to get energy is compromised, get energy using oxygen is compromised. And I keep showing, cancer cells can live in hypoxia without oxygen. Cancer cells can live in cyanide. Cancer cells can live with respiratory poisons. They do fine. Normal cells are killed instantly, but the cancer cell is not, because it's not using oxygen for energy. So oxygen consumption itself is kind of giving you misinformation, misdirecting you. But over the last 10, 15 years, many people doing energy metabolism in cancer, they went out and bought the Seahorse instrument. It's a very sophisticated piece of equipment that measures oxygen consumption and extracellular acidification using indirect formulas and things like this. And they have become, everybody feels that you need to do Seahorse research and all this kind of stuff. And it's giving the field massive misinformation. So, and that's another thing that nobody wants to really hear about, that I went out and bought all this expensive equipment, and now you're telling me that I'm getting misinformation from it. And the answer is absolutely, because we did all the experiments to test all this stuff. And cancer cells don't live in oxygen. They can grow without oxygen quite fine. And so that tells us they're fermenting. And that comes back to what we did. We interrogated the cancer cells from different types of cancers and just said, okay, what can you guys grow on? And we took everything away from the tumor cells, put them in nothing, in just salt water, the salt solution called buffered salt, phosphate buffered saline solution. And they're in there and they all die. Okay, great. So let's do it again. Every cancer cell living in just salt water, phosphate buffered salt, dies. All right, great. Then we give them back Dubeco's essential modified medium, which has a few amino acids in there, and put them in there. And they live a little bit longer, but then they croak. Okay, the cancer cells are all dead in DMEM, which is kind of a cocktail of some amino acids. So they don't live in salt water, and they don't live very long in this DMEM. Okay, great. Now we know that they need something to live. And then we add back all the different sugars and amino acids, and we add everything back, and then we try to find out what they need to live. All right. So we threw cysteine, methionine, we threw all the different amino acids, you put in glucose and you put in glutamine, and these things are skyrocketing. Now, they can also live on some other sugar like sorbose, but we don't have sorbose in our diet. We don't have sorbose. So nobody's going around chugging glasses of sorbose. So, but cancer cells can live on that kind of a sugar as well, but we don't have that. Also, what you find out, there are some other, like asparagine. They can hang on a little bit with asparagine, but they're mostly dependent on glucose and glutamine. So we can't find any other fuels that can replace glucose and glutamine. So people say, oh, the cancer cells can live on ketone bodies and fatty acids. Oh, yeah? Take away glucose and glutamine, put ketones and fatty acids, and they croak just as fast as they were in the salt solution. Now, if you take glucose and glutamine and add fatty acids, they can grow a little faster because fatty acids enhance the use of glucose and glutamine. So we went through all of these different conditions, stripped away everything, and just ask what these damn cells are capable of doing under stringent conditions. What do they need to survive? And we found out what they need to survive. They can't live without the glucose and glutamine. And these two fuels work synergistically off each other. We've got a beautiful paper here. It's unbelievable. We're going to be publishing this in a not too distant future. This is how the two fuels are driving the beast. We have them, they're straight shots through. These two pathways feed off of each other, allowing those tumor cells to survive. And you got to shut the two fuels down together. You can't take away one because they kind of hang on with the other. You hit that one and they hang on with the other. You got to hit those two fuels together and force the body into a restricted ketogenic situation because they can't burn ketones. You need a good mitochondria to burn ketones. Cancer cells cannot burn ketones. So when you hear all this crap about, oh no, some cancer cells, no, they can't. We tested them. They can't. You show me the evidence that a tumor cell can burn ketones in the absence of glucose and glutamine, my hat's off to you because I haven't been able to find it. So when you start to restrict everything down, you know what these cells have to survive. And if you know what they have to survive, they need energy and they need metabolites to grow. And those two fuels give the cancer cell everything that it needs. And it can't use other things in the environment. So the logical way to manage cancer is to take away the two absolutely required fuels and transition the body over to fuels that the tumor cells can't use. And you will annihilate, for the majority of cancers are all suffering from the same. Can you believe this? What I just told you? Can you comprehend what I just said?
Wow. I've looked at a lot of your work, so yes.
It's unbelievable. And then go down to your local cancer clinic and explain that to them. And then you give them the paper. You say, listen, here's the evidence that what I just said. And they look at it. Oh, wow. This is really, really, I'll read this and I'll get back to you. And they never get back to you. So, not never, but most of them, they look at it and you might as well be, whoa, what is this? Oh, I don't know. Now look at this guy. This is a nice paper with a man who had metastatic lung cancer. He had radiation and chemo. He had chemo. It was in his lung and it metastasized to his brain. And he went through the standard of care. The cancer continued to grow. And my good friend, Dr. Athanasios Evangelio in Greece, immediately transitioned him over to a calorie-restricted ketogenic diet, which isn't really too bad. It had lamb and olive oil and things like. It was actually kind of a Mediterranean diet. And this guy's alive 9 years later. I mean, he should have been dead 9 years ago, right? So, well, this is only an N of 1. Oh, N of 1. What about Pablo Cat? Why don't people read about these papers? Why don't you read about this guy who should have been dead 8 years ago? Why is he still alive? And he's not cured, but his cancer is there, but it's managed. And here's the papers. Everybody can go on the web, on Google, and Google these papers and read them for themselves. Right? This is not hidden behind some wall of the medical school. This is out there. It's on the internet. So people can read all these papers, and then they can read them carefully and say, well, this is really interesting, but I don't know if I can use that.
Well, I think part of the problem is, and this ties back to something I was talking about before, but to further elaborate on that, is the time factor for people, because people aren't digging into this knowledge base and learning about it before they have cancer. It's going to be people that have cancer and they're on a timeline, and then they still have all the pressures of, family life and stress and go lifestyle and money, and we could go on and on. So it's like, I really feel for people when they're just looking for what they can do practically put down for them, because they don't have a lot of time and they're exhausted.
Yeah.
You talk about the fact that when people get the cancer diagnosis, their cortisol goes up. Yeah. And then they end up spiking their blood sugar, which is feeding the cancer. Like there is a lot against people. And that's why this is why I wanted you back on again, because the best thing I think me and you can do is get this information out to people and try and guide them. And as there's clinics, give people the knowledge of where these clinics are, because I'm a middleman to help deliver the information. You're the scientist, and this is what we can do.
Well, I think the clinics are the ones that you have in everybody's major city. Those are the clinics that should be adapting this, because, and but don't get me wrong, there are metabolic therapy clinics that are starting. I know there's one in Switzerland. I know there might be one in Arizona, but they're not there yet. There's no place that you can go when people say, he talks about this, but where do we go? Go to your local hospital. Ask them about it. And then they say, well, I never heard of this. And so I feel bad for the poor patient, because the patient hears what I'm saying. There is hope here. There is a way to manage this disease without toxicity that could be quite effective in keeping people alive a lot longer. But yet when they want a professional guidance on this, where do you go? Okay. I've been able to do it on 1 or 2, 3, 4, 5 case reports. And our canine paper just came out. So this one here that everybody's been talking about, how is it possible that you could use a resolution of malignant canine mast cell tumor using ketogenic metabolic therapy alone? No chemicals, no radiation, nothing. And this dog is fine. And you can look at the pictures of the dog, and you can see how clear. And that's another thing. In these major hospitals, when you treat cancer, you like to say, I looked at all the heat maps, the gene readouts. I looked at the mutations, and I looked at this, and I looked at that, and I try to figure out. In our case, we had nothing to study. It was gone. Resolution means no cancer. There's nothing left to study. What can you do? Where's your data to show? All I can show is the face of a dog that had a big tumor, and now he has no tumor. From a radical change in diet. And I see the same thing happen in people too. So a lot of it, Jesse, will fall on the shoulders of the patient themselves. I give them information. They can read it. Is it easy? No, it's not easy. But it's there. They have to spend a little time. You have to have some level of scientific literacy to understand this. So it's not like going down to your local oncology center and having them do a biopsy and telling you have this kind of a cancer, and now we're going to institute a program to manage your cancer with toxic radiation and chemicals and immunotherapies and CAR-T all this kind of stuff, and or telling you go home and start cutting back on your get your blood sugars down, your ketones up, get yourself into a state of. In fact, that's what we had with the press pulse therapy, because I think people need to know about that. And this is the diagram for that. And as you can see on this paper, you have the red guy full of cancer. He's got type 2 diabetes. He's got high blood pressure. He's got all kinds of stuff. And then slowly move him to the yellow, where the cancer becomes less deadly, less complicating. He starts to get a little bit healthier. And then we slowly degrade, as you can see, the different kinds of drugs and diets that you use. And as you said, emotional therapy to reduce anxiety. All of this is part of the package for healing. So this is a strategy for healing. And as I said before, the body will heal itself if you give the body the opportunity to do this. So it's a planned strategy to manage cancer, and it will work, and it does work. The problem is it's not yet ready for prime time in any of the major medical schools. And I don't know how long that's going to take, but maybe your audience, the people that listen to this, they're the ones that will put the pressure. They're the ones that have to make the change. I can give you the directions, the protocols, and everything else, but if the hospitals aren't using them, then what do? The people have to demand it. The people have to want it.
I want to go over some of the specifics on that last page you showed in a minute here, but first I want to show some empathy for the medical doctor out there who is practicing medicine in a classic sense, because we've talked about this on our previous chat. His or her hands are basically tied because they have to follow standard of care. And as a second layer onto that, if they listen to this conversation today and then go into the hospital tomorrow and start talking about some of the stuff we're talking about today, they're going to get laughed out of the room. Like, you know what I mean? Is it enough for one doctor who wants to take a stand to even do anything? And this is why, again, the patients...
Yeah.
We'll see how it all plays out. Hopefully there is an answer and it does play out in a positive way over time and hopefully sooner than later, but it might have to come from the patients because these classically trained docs, again, hands being tied and their colleagues just aren't going to listen if they bring this up.
You know, it's funny. I speak to so many physicians, oncologists and whatever, and the ones that know that I'm right are usually the ones that have retired. Yeah, they can't say anything when they're actually working. But as soon as they retire, they come to me and says, "You are 100% right, man. I can support everything you're saying." But they can't say it when they're working for the very reasons that you just mentioned. And how do you change the system? This cancer system is broken. It's a broken system, treating patients on a flawed theory of what the actual disease is. People are suffering and dying. We're using medieval kinds of approaches to manage these people. In little kids, we're working on a therapy now for childhood brain cancer that's far less toxic and more therapeutic. Again, we have a beautiful preclinical system for this. We can publish it, and then you go and try to get into the clinic for the person who has a little kid that's suffering from a brain tumor, and they won't use it. So we're going to have the same problem up and down the path. How do we change that? That's right. We have the science. We should be in the right direction, but we're not doing it. So why are we not doing it? And then you have to kind of dig deeper. And a lot of it has to do with something other than the science. You know, obviously there's something else going on here. I mean, if the science tells us we should go in this direction, and we have the hard preclinical evidence and case report evidence to say that we should be going in this direction, and we're not going in that direction, then why are we not going in that direction? So why are these poor folks that listen to this, get some level of hope, and they go to their cancer clinic and they don't get anything what I'm saying, and they get ridiculed and sometimes told to leave? Now, this is unacceptable. And I understand there are physicians that understand what I'm saying, and they wish they could do this, but the system does not allow them to do it. So what's the system? Who's in charge of the system? Who is this so-called system? Okay, there's nothing being suppressed here. There's no conspiracy here. This is clearly there, isn't it? I'm talking, you're listening, people are listening. Well, why is this not being done? And then you have to say, there's something else going on here. There's got to be it's just ignored. It's not being suppressed. It's just basically, why is it ignored? What is wrong with the science that we have shown year in and year out with the success stories that we have. Well, you didn't do a big clinical trial. How can we do a clinical trial when the very people that would be participatory in the trial never heard of this, know nothing about the biology, and you're treating patients with folks that really don't understand what the situation is? Who's going to pay for the clinical trial? Right? I mean, you got to think about the cost of the physician's salary, the beds in the hospital, the tests that we do to ensure that something is working in the right direction. I mean, all this costs money. So who's going to pay for this kind of a therapy? Are folks that have breast cancer all going to get their money together and say, let's do a clinical trial in metabolic therapy for breast cancer? What they do is they run Susan Komen pink ribbon campaigns, and everybody's out there, jogging, and they raise like millions of dollars, and then they give it to Dana-Farber, MD. These are the same guys that are contributing to the problem in the first place. So what are you going to do? I don't know. Maybe that's beyond my pay grade. So, but all I can do is present the hard evidence to say that we should be doing this. And if you don't do it, then there must be some other reason for why you don't want to do this. And the clinics are in the major hospitals. So don't say, I want to go to a clinic that does metabolic therapy. Well, go down to the James, MD Anderson. Go to MD Anderson and say, listen, why are you guys not doing metabolic therapy? Get the answer to, well, we can't do metabolic. It hasn't been done a clinical problem. They give you all kinds of superficial things. And if they say, well, the science really hasn't been established well. Oh, yeah? Where? You show me the paper. Poor patient can't deal with this kind of stuff and shouldn't have to deal with this kind of stuff. I deal with that kind of stuff, but I can't. I'm not a physician. I can't treat anybody. I can't tell you what to do or what not to do. All I can do is publish my research, show that it works. It doesn't work on a mouse. He said, those mouse studies, they're not relevant, these mouse studies. Oh, yeah, well, what about the dog? The dog responded even better than the mouse. So your dogs are irrelevant now, too? It works together on a couple of case reports of guys with terminal cancer. I mean, it works on them. It works on people and dogs better than it worked on any of our mouse models. I can tell you that. And all of our data were coming from a poor model of cancer, and we're getting results. It works so much better in humans and dogs. Jesse, tell me, what do you think about all this? I mean, let me hear what you say.
Oh, I've been saying a lot.
I know, you're asking me very good.
People have a pretty good.
I want to hear what I know you are. You're asking questions, but the
no,
question is now
I'm stating my feelings too, and guiding us here. But one thing I want to point out is you did drop a hint there. The fact that there are a couple of clinics, I think you mentioned one in Arizona and one in Switzerland.
Well,
so people can at least have a little bit of a crumb there to do some searching. The other thing I want to mention quickly is I've heard you talk about, and I think even early in our conversation, you quickly mentioned it, these kits that you send to people if they reach out to you and they feel hopeless. Talk about who can get one of those and what's in there.
I give them because they email me, and I have a kit. All it is just basically telling people that if you can get your blood sugar down, your ketones up, you have a chance to reduce the rate of growth of these tumors. And in fact, our press pulse concept that was I showed you evidence for the little meter, the Keto Mojo glucose ketone index. And that's another thing too. A lot of people come to me and they say, I take take a little drop of blood and I put it on the stick and I put it in the meter and it gives me my glucose. And then I take another drop of blood and I put it on the stick and it gives me my ketones. And I push a button and it gives me the ratio of blood sugar to blood ketones. And we've published what we think is the zone, the therapeutic zone that slows the cancer down and gives you an opportunity to plan out options and things. And a lot of a lot of people will tell me that, I can't get I've done everything and I can't get my reading. I can't get into the zone you're telling me. And then you find out that they're also being treated with steroids and radiation and other things. And all that stuff prevents the body from getting down into these critical zones of therapeutic healing. And so that's one interference, and they struggle and they do this and they do that. Most of the people that I see who can get into these zones don't have any chemoradiation. Like all the guys that these folks that I'm talking about, they were not hampered by toxic treatments in the body at the same time. And then people say, oh, I've been eating these vegetables and I can't get well, stop, try something else. There's foods that spike blood sugar, and then there's foods that do the same thing. I know it's very hard. Believe me, I'm not going out there advocating people just drink water for 14 days or 15 days, because it's hard, but people can do it. And as I said, I can't go out and tell people, and I can't tell them anything, but I can't say, oh, the only way you're going to manage your cancer is don't eat for 30 days and just drink water. But there are people that do that, and they do get success. But that's not what most people want to hear. You have to have a therapy guided by professionals that will allow you to help you get into those zones. Miriam Kalamian, she has a service. She's a diet nutrition certified person who knows and helps many. She wrote many patients get into these zones. She wrote the book Keto for Cancer. People must look at what they're eating, how much they eat, the combinations, and then you'll slowly start to see getting into these zones. And then once you're in the zone, then there are non-toxic drugs like these parasite medications that really do a job on these cancer cells, but they don't work unless you're in this metabolic zone. So again, it's a planned procedure. You just can't go out and take certain kinds of drugs and expect to get it. The diet alone will be very helpful. It's the diet with the specific kinds of drugs that target glucose and glutamine simultaneously. That's the key. You got to be able to get your body into a state that accepts the drugs in the right combo. And that's called, we're working on that dosage, timing, and scheduling. And that's the cutting edge right now. So that's where our money comes. When we get, most of our research is supported by philanthropy and private foundations, because they're more allowing us to do pretty much what we need to do to move the needle forward, move the needle on this whole thing. And we have the best people that work with me for years on these preclinical systems and interrogating these cells. So once we know and we put the package together, we can train people to do this and help them. But there's a lot of variables here, Jesse, and we're trying to do the best we can to help these people, and know that we're right, and know that this is going to help. And it does. From what I see, it's going to help a lot of people. But I feel frustrated in not being able to tell them, go to this place. If you want to go to the clinic in Istanbul, where they have had some success. Success for everybody? No. Who has success for everybody? No place has success for everybody. But do we have a better outcome than some other places? Absolutely. Will the future allow people to build clinics that will treat people with metabolic therapy? Maybe. I think it will be very hopeful. I've worked with a lot of knowledgeable people that would be wonderful in treating cancer patients. We need MDs. We need MDs that are licensed to treat people, but they need to be able to have the flexibility to do this. And right now, as you've clearly mentioned, they don't have the level of flexibility to integrate these protocols into a treatment for their patients.
If you enjoyed that clip, press here for the full episode. I'll see you over there.
And I have the science to say what you should do, but it's up to you to determine whether or not you want to do that. The body will turn on the tumor and dissolve it and eat it together with the diet drug combination.